Dr. Lopez has partnered with a variety of systems to implement or evaluate zero suicide initiatives and currently serves as the principal investigator for the early psychosis intervention in Texas. Emily Dirksmeyer is a licensed clinical social worker and technical assistance coordinator for the Office of Forensic Coordination at Health and Human Services Commission. Emily supports the state forensic director by facilitating collaboration among both internal and external stakeholders at the intersection of behavioral health and justice and provides tailored technical assistance to communities across Texas on improving forensic services and reducing justice involvement for people with mental illness, substance use, and intellectual and developmental disabilities. Emily also serves as the team's juvenile justice subject matter expert to support early intervention and diversion for youth at risk for justice involvement. Emily received her Master's of Science in Social Work from the Stephen Hicks School of Social Work at the University of Texas at Austin, and she also holds a bachelor's degree in psychology with minors in sociology and Spanish from Texas A&M University. Thank you for being here today.
All right, thank you all. Good morning. Thanks for joining us this morning. I know probably Friday mornings are hard. Thursday morning, sorry. It feels like a Friday. The last day of the conference, though, is always a little bit hard, right, to kind of make it to all the things because we're a little tired. But thank y'all for being here today. We're gonna give you a little bit of a context setting, but this actual event is really going to be a discussion. So we're going to kind of involve you, engage you. We're going to learn from you. That is our focus this morning. Okay, so plan to kind of get your thoughts moving. We're going to get up. We're going to move around. We're not going to sit still. So. All right, so I'll get us started, and then I'm going to pass over to Emily to kind of do some context setting as well. But we are going to talk about suicide prevention and about some of the challenges that we have nationally in our state around young people. So this first slide that I'm going to share is a little bit looking at, not a little bit, it is looking at leading causes of death over a period of time. So I'm just going to let it play for a little bit and kind of let you kind of figure out what you think it might mean. Okay, I'm going to stop. I'm going to go back for a second. What did anybody notice? I know it goes by fast. Yes, I'm going to repeat what you say so for the people online. Yes.
So I noticed that unintentional injury is the top of the list, and then suicide just like climbs up and up that list. But I'm wondering if those unintentional injuries are directly related to suicide, because there are a lot of teenagers who try to attempt suicide, but sometimes they fail. So they unintentionally cause the injury to themselves.
Okay, so for those online who weren't able to hear that in the room, the comment was wondering if the unintentional injuries and sort of it being the leading cause might also include some deaths by suicide where it wasn't really clear, where medical examiners may feel better providing that kind of rationale if it wasn't really clear. I think there are a lot of factors that relate to that, and I think you have a very good point, and I suspect it's very true. Anybody else have anything that they noticed that was interesting? Yes.
On Zoom, they're saying, as we've become better at treating disease, suicide has become a higher cause of death.
Oh, yes. Did you notice that? There were sometimes even new diseases that kind of came in, but we started to kind of think about how do we solve that, and you started to see it go back down, right? And suicide then moved up the list, right? So we've got multiple factors going on. Not only are we probably underrepresenting the deaths by suicide in this population, and many of those may be showing up in unintentional injuries, we also have seen suicide not only kind of go up in its ranking, but it also steadily increased. Well, not steadily every year, but it has over time gone up, whereas some of the other leading causes of death have actually started to go down because we're doing a better job in our medical field of treating those things. So very good point. So that kind of leads us to this report that came out in 2012 with that very concept of, look, healthcare field, we're doing a great job in many of the common diseases that are leading to death, but we're not doing such a good job in suicide, right? We're not doing such a good job as a healthcare field in really understanding how to recognize people who may be at risk for suicide, intervene with them, and help prevent those unnecessary deaths. And so this report really focused on how, as a healthcare system, we can do a better job of preventing deaths by suicide. They focused on some of the novel things that were happening in the country at the time, including things that were happening at Henry Ford Medical Center, which is a really large kind of medical system, the VA, the Air Force, some of the things that were happening, and said, what are they doing differently here that seems to be having some effect? And what they found as they did those investigations is that those that were doing well were thinking about it structurally. They were thinking about it as an organization. And so what they did is they came out with this report that said, we really need to think about suicide prevention not as kind of a one, like, we need to do this. We need to train people in warning signs, or we need to offer this DBT intervention. No, what we need to do is think organizationally and structurally. How do we do this differently in a big scale? And so they talked about things like, how do we set the core values of our healthcare system that we want to ensure that nobody dies from suicide, that as healthcare providers, this is a part of our mission, part of what we do. They said we need to think about how systems are managing themselves to look at deaths by suicide, to look at whether or not we're really meeting the goals that we want to have. And they said we need to be thinking about how do we incorporate evidence-based clinical care practice into those healthcare systems. So it's kind of revolutionary at the time in the healthcare system. Say, we've got to think about this differently. So out of that came this movement called Zero Suicide. And Zero Suicide is really, sometimes that is hard for people to even hear or think about. But it really is this foundational belief that says, as a healthcare system, we need to focus so that we are not accepting any deaths by suicide. It's an aspirational goal, but when you stop and you ask yourself, what's the metric that we're okay with, right? Is it that, we're okay with 100 people in our healthcare system dying by suicide? No, not really. Right? So really, zero is our goal. That's kind of where we want to get as a system. And so that framework, which has really started to be built out, it's really caught on. Even some of the accreditation organizations that accredit different healthcare systems have kind of really adopted this as being a part of how we think about things, which is really great. It's really been applied though to the health and the behavioral health systems, and it's catching on It's doing well. Here are some of the components, just so you kind of have that context. LEAD is about that culture, that organizational leadership, really being committed to that change. Training is making sure our workforce is competent and has the skills they need, and not just specialized providers, but all of our workforce, including the people that are checking people in at the front desk, who may be the ones who are seeing the warning signs. Identify is our ability to recognize those at risk, usually through screening and assessment. Engagement is about bringing those people who are at risk quickly into a pathway, a mechanism to support them, to keep them safe. Treatment is about how do we ensure that people are getting access to the treatments that we know are evidence-based in directly impacting suicide risk, right? Not just focused on other symptoms that they may have, but the things that are directly related to their suicide risk. And then transition is recognizing that as people move between providers, move from one provider to another provider, that those are times at increased risk. As we come out of the hospital system into an outpatient system, those are times at high risk. So how do we make sure that there's not gaps there? And then improve is focused on the data. How do we ensure that we are really looking at what's happening and if our systems are improving in the way that we expect and if we're getting the outcomes that we want? And if we're not, how are we quickly making some changes in that so we get there? So that's the zero suicide framework that's going on. There's a lot of good evidence for some of this. So I'm putting this in here just so you have it in your slides. I'm not going to go through the research, but there is both evidence in the past as well as growing evidence. And Texas has been doing a lot of this. It's really, in some ways, we've been at the beginning of it for a long period of time. So we have over 10 years experience in implementing zero suicide in the public mental health system. Many hospitals and clinic systems have now implemented zero suicide initiatives. It's really picked up steam. And the approach has also been adapted for schools. And there's work going on right now to support schools in building components of these practices into the schools as well. All right. So, what about the juvenile justice system?
All right. So I'm just curious, before we jump into how zero suicide translates to when we're thinking about supporting juvenile justice stakeholders, I'm curious who in the room works with youth at risk of justice involvement or youth who are justice involved. Just show of hands. Okay, nice. My people. Awesome. So I think a lot of the data on this next slide's not going to be news to y'all. You know who we're talking about. We know what the risks are for this population, but just really quickly, and this is national data. We don't have a lot of this data at the state level, but nationally speaking, it's estimated that about 70% of youth arrested have a mental health condition, as compared to around 20% of the general population having a mental health condition. And so obviously significant when we think about risk for justice-involved youth or youth at risk of justice involvement. 90% of youth involved in the juvenile justice system have been exposed to at least one traumatic event. And that traumatic event is defined kind of using the ACE protocol. I think one traumatic event, we could probably estimate that 90% have a lot more than just that one. And then youth in juvenile justice residential facilities have nearly 3 times the rate of suicide compared to their peers in the general population. So again, really, really significant when we're thinking about this risk. Back to the data that Dr. Lopez put up, thinking about the risk and how death by suicide has just increased over the years. But also just thinking when we zoom in on this population, how profound that risk is. And then I think the last stat of suicide continues to be the leading cause of death for youth in custody. I think that's really, really significant when we think about intervention and think about how to apply this framework. So really quickly, I'm not going to go in great detail, but who's heard of the sequential intercept model? Okay, a couple of people. So my office with HHSC, Office of Forensic Coordination, we do a lot of strategic planning at the county level. So we travel around the state, we implement this model, which really looks at how folks with behavioral health needs come into contact with and move through the criminal justice system. And as y'all can see, a lot of the points or the intercepts that are outlined here are adult focused. So it's looking at the adult criminal justice system. And this is a national best practice tool that really kind of helps us take that systems lens of not just what am I doing in the community as far as a community-based mental health provider, but how does my work connect to each of these intercepts, and where can we think about opportunities to divert or improve treatment for folks with behavioral health needs. So again, this is a national best practice model, and my office has implemented this in 22 counties now across Texas. There's 254, so, a drop in the bucket. But with that, we noticed that a lot of communities were saying, what about our youth? What about our youth who, are high risk, who are coming into contact with the juvenile justice system? So we developed a Texas-specific youth SIM model. And we worked with agencies across the state, Texas Education Agency, DFPS, TJJD, HHSC folks, and then local county stakeholders. So chiefs of juvenile probation, folks like that. We're all at the table to help us take the image from the first slide that I showed, the national model, and really think about what are those diversion points for youth when we think about youth who come into contact with the juvenile justice system. So how does this relate to zero suicide and what we're talking about today as far as opportunities to prevent suicide among this population specifically? Well, it gives us kind of a framework to think about where those opportunities to apply the 7 pillars of zero suicide are. So really, when we talk about zero suicide for juvenile justice stakeholders, which is what we're focused on, we're talking about that intercept 2 and 3 piece, where you can see 2A is initial detention, and then thinking about placement and probation supervision. This is a very generalized view of how we know youth move through, but thinking about continuity of care from the perspective of not doing the work in a silo, but thinking about particularly as youth are transitioning, when that risk of suicide is higher, how can we integrate across stakeholders using this model to kind of think about it? So I love the SIM model. I feel like it really gives an opportunity to map out what gaps, what opportunities exist in communities. And I think it's a great way to think about how we apply zero suicide or think about suicide care in juvenile justice settings. So with that, I want to make sure we have plenty of time to get to hearing from you all and learning from y'all. But something that Molly and her team have been working on is developing the Zero Suicide or Suicide Care in Texas toolkit. So this is something that is on the horizon, that is actively being worked on, and really takes all the information that was presented on at the top of this conversation and applies it specifically to juvenile justice settings. So as Dr. Lopez mentioned, this framework has been applied in healthcare settings predominantly, has been implemented in schools now, and now we're kind of looking at what does it look like to bring this framework to juvenile justice stakeholders. Really thinking about the specialized needs, the nuance that comes when we're talking about detention settings, when we're talking about secure placement settings, and what does it look like to think about safety planning and prevention and effective assessment at those specific locations. So the toolkit is one piece of that. Also developing a learning community, which we will be opening applications for this learning community in the fall. So I would say the best way to find out information about that is through the Texas Behavioral Health and Justice TA Center. This is a website that our team has, and we'll be launching everything related to the learning community with applications on there. Wish I had put it on this slide, but I'm happy to share it too. Texas Behavioral Health and Justice TA Center. I can get you the HTML specific site, but if you Google that, it should pull right up. There's a lot of cool resources on there too, just a plug. But that's a way to access when applications open for this learning community, and the target will be, again, juvenile stakeholders. So we're really thinking about narrowing it in to detention-based settings, thinking about training staff who work among the 39 detention centers across Texas. Or maybe it's 49. I always get that number wrong. But either way, partnering with communities at the local level, and then local behavioral health and mental health authorities also at the table to think about implementing this framework. And then we'll have training as well. But more to come on that. To stay up to date, for sure, check out the TA Center. And with that, I think we can go ahead and move to the activity here. So I'm sure some of y'all noticed there's these poster boards around the room. And what we want to do today, again, just giving y'all a really brief idea of zero suicide, thinking about how we want to apply it. We're wanting to identify the strengths, weaknesses, opportunities, and threats, also known as the SWOT analysis, in our efforts to strengthen suicide prevention and suicide safe care for youth involved in juvenile justice. So we want to go ahead and think about splitting into groups to target these 4 quadrants of the SWOT analysis. So thinking about strengths as what does the juvenile justice system do well in preventing youth suicide? What's working, right? So strengths, thinking from y'all's expertise and your experience, what's going really well? Thinking about weaknesses, what suicide prevention efforts are not performing well or could be improved? What gaps exist? Where are we lacking important resources? Then opportunities, what resources can be used to address any weaknesses in preventing youth suicide? What would motivate the system to improve? And then threats, what things outside of our control might prevent us from making changes? So those are like the big barriers to change that you all are experiencing in your line of work or in your community. So with that, we have 3 kind of stations around the room. And what we want to do is break y'all into groups to kind of have a conversation about these 4 pieces. And then we're going to ask you to take some time to write some of the themes that have come out from y'all's conversation on your respective poster boards. So looking at the room, I'm thinking this group, so front 3 rows with this sticky over here, and y'all can kind of turn your chairs however is comfortable for you. Back row and this middle group together on this back post-it kind of near the back row. So I don't know if y'all want to like work over here and then populate the stickies. We have sticky notes and we have markers to write directly on it, however you want to do it. And then this group, y'all know the drill. It's this one over here. So really, we just want this to be an opportunity to have conversation, for y'all to learn from each other and for us to learn from y'all about how you're currently doing the work with this population, and really what are the barriers or the opportunities to improve it. Okay, any questions about that? I know I ran through that pretty quickly. No? Okay, awesome. We love group work. So we're gonna go ahead and get that started, and Molly and I will be floating around to answer any questions.
And I just wanna say really quickly, we really are informing this from folks like you all, right? We wanna know where you see opportunities for us to help support. And so thank you in advance for kind of lending your expertise to this work. All right, go. Okay, so Emily's gonna write up that number on the board for the URL, so that you have the link to the TA Center if y'all want to take a picture of that. I'm going to come around because we're hoping to just kind of debrief a little bit about some of this. I could tell in the groups that I went to, there was some awesome discussion happening. So I'm going to start. Let's start with strengths. And there can be anybody who's willing to kind of share. It doesn't have to be just your idea. It can be just a cool thing that your group talked about that you think is helpful. So what did y'all come up with? What are maybe a strength, something that's working well right now that we want to make sure we don't lose? Or, I'll stop that. Who wants to share a strength that they heard? All right, awesome.
Good morning. One of the things that we listed as a strength in the group that I worked in was prevention programs, training, and then also when juveniles are brought into our juvenile justice system, particularly the intake unit, there's usually like an assessment tool or a MACI to where we ask children a series of questions to determine the probability of suicide, which would include depression, anxiety, and anger.
Awesome. Okay. So some good screening and assessment happening as folks come into intake. We want to make sure we don't lose that. We keep doing that. Okay. What else? Anybody else have a strength they want to share? Oh, awesome.
I don't know about all the different counties, but I live in Hunt County, and our probation officers are super good with working with the community. They will reach out for help. They will do everything that they can to help these kids, and I do think that that is a strength that they have, the probation itself.
Awesome. I actually heard a couple of strengths in there. I heard that community collaboration and partnership, and maybe I'm reading into it, but I think I'm right. You feel like they've got some heart for really reaching out and doing everything they can for the kids. Yeah. Yeah, I want to point that out and celebrate that because that's something we definitely want to keep going. Yeah. Anybody else have a strength they want to share? All right, let's move on to weaknesses. Anybody see some gaps or areas for us to continue to improve? Especially if it's something that might be helpful as that we can kind of help create some resources around.
We said that there's a lack of employment and staffing in these agencies.
Okay, workforce shortages. Did y'all talk about any particular roles or just kind of across the board?
Just across the board.
Okay, awesome. Other gaps. What else did y'all talk about as areas we could grow? And Holly, if you have any that you want to share from online, I'll rush a mic over to you too. Awesome.
Another area that our group talked about was the poor parent involvement, getting the parents involved and making sure they're aware of some of these signs or that might lead to their child engaging in that type of behavior or suicidal ideations.
Okay, awesome. I know I heard some discussion as well in the group that I was sitting in about kind of helping to educate parents, right? Making sure that they have the information they need to know how to identify kids, what's going to happen next, where are the resources that I can turn to if I'm worried about my young people. So yeah, thank you. I'm going to pass this off to you if you don't mind, and then I'll just run I'm going to do opportunities.
Sure. Okay, so we've talked about strengths, weaknesses. Moving on to opportunities. What opportunities exist? What would you guys want to see to improve upon some of these weaknesses that we named?
One of the opportunities that I saw, I went to a cadet fair before when they were going to become police officers, and they're really open to it. They would come to our table and ask, okay, so what do I do? What are the resources? Where can you direct me? Who do we call? So I think there's that opportunity for, future police officers to actually get involved and be educated in mental health and what they can do to help our kids out.
Yeah, sure. So really just bringing in law enforcement to the fold, really providing that tailored training, thinking about how to coordinate with them to get, youth connected to care and identify potential risk. Great. Anyone else? from some folks online.
Couple from our online. Create a mental health professional training track at juvenile justice conferences like JJAT to engage with JPD employed mental health professionals. And then also collaborative training between JPDs and LMHAs to address how youth crisis will be handled in a county. So the youth sim workshops could help here.
I love that plug. So yeah, just thinking about training and collaborative training for both juvenile justice stakeholders and also behavioral health providers, thinking about opportunities to use conferences like this to improve that training. And then youth sim mapping, which I love. And we're launching that in the fall. So check out the TA Center. We'll have some of that available for application. All right, any other opportunities? Yes, ma'am. Molly's running.
So our group came up with two type of opportunities. One was a program to help navigate the coping skills. And then another was the opportunities for the safety plans that are needing to be put in place for not only the client, but the family, so that they're well aware of what needs to happen.
Great. Those are great opportunities. All right, anyone else? Opportunities? Okay, so finally, thinking about threats. So outside of our control, what might prevent us from implementing some of these changes? Yes, sir, in the back.
Legislation that has been passed.
Legislation that was passed.
Yes, that they limit or has not been passed.
Okay.
That were designed to help our kids, and and we can't help that. We can't change that right now, so we have to wait.
Yeah, legislative change is a huge barrier. Huge. I hear budget over here. I've never heard that before. Just kidding. Definitely budget. Funding for these programs, and also thinking about how to pull from these different stakeholder groups to support funding any of these programs. Information sharing and all that as well, MOUs, ROIs. Y'all know.
Yeah, I was gonna say the same thing. Lack of funding. What we've seen in Houston is the resources are out there, but there's long waiting list for those people that are not able to afford it. And, so just the lack of funding, long waiting list. We are able to identify the red flags, but when it comes to actually helping the kiddo, that's one of our biggest barriers.
Yeah, the connection between identifying that there's a risk and a need and then really getting that child connected to treatment. Yeah, due to lack of funding. All right, anyone else? Threats? Okay, I think that we're nearing time. I don't know.
Yeah, I think we are. Maybe just a couple of closing comments. One is just a big appreciation for you all and for the great ideas that you shared. We're going to take all of this information, including what's online, and bring it back to our team who's creating these resources, and it's going to be super helpful. Just a quick housekeeping reminder, make sure you check off that you are here for your CEUs on your roster. The survey link is at the door to scan for you to do your surveys. And we've got some great closing speakers and presentations in the main big ballroom next. So we hope you'll continue to join us. Thank you so much.
Thank you all.